Hello and welcome to First Friday Fertility Live. I'm Dr. John Preston Parry and I am here talking about the Periscope technique. So we are going to be talking about how do you go about seeing if you can get pregnant, what are the core building blocks for female fertility, and how do you do it in a single visit. And well, there are all kinds of other things that we're having for fun announcements. First, I want to pull in Dana here. Dana is our newest nurse. Come on over, say hi to everyone.
Hello.
Tell us about yourself or anything, put you on the spot for everyone.
My name is Dana Croxdale. I've been a nurse now for 14 years. Have a history in emergency room and cardiology, and just really excited to be at Positive Steps. Really wanted to shift my career and just doing something that I think is just amazing work, really giving back to patients and just the core of why I became a nurse. So I'm really excited to be here.
We love her. She is awesome, and so we're very lucky. Thank you for being on the team and everything. I will. She has to still see our style for things before I put her on the spot and start having her answer your questions live. That is always. It's funny, I talk a ton, so I tend to be comfortable with just on the spot for a lot of these questions. Usually for the team members, if I just drop the mic on them and they're ending up having to do it as causes, the most calm and normal people who could handle practically anything. I don't know. Something about being on a live video puts a little bit of pressure on people, but they are an amazing group, and I'm very fortunate and blessed to be with the people that I am. The other thing, by the way, we'll also talk about for this is that we're doing a fundraiser for ASRM, American Society of Reproductive Medicine. This is I've shared it on my personal page. I'm going to be adding it to the Positive Steps fertility page shortly, but we are trying to figure out how to raise money for reproductive research so that couples can really have cures for fertility effectively. So in terms of the, Melissa, by the way, could you close the door for things? Sorry. Or Dana, if you could, she already left. Okay. Outside noise. The whole team is here and everyone's busily working away. So I think, again, one of the things we're passionate about is not just, the give a man a fish, but also teach a man to fish. How do we do something that sort of ultimately moves the needle forward for our entire field? And I have so much respect and love for the American Society for Reproductive Medicine, which is the parent or national organization for fertility with a lot of emphasis on reproductive research. And so for my birthday, I'm doing a fundraiser. I'm going to row probably about 15,000 meters. We'll see if I can beat that, but I'm going to be on the rowing machine until I pretty much fall off. I think that was sort of the goal for it. You'll see some pictures. I think one of the posts has a picture of me from 33 years ago rowing, and apparently I look a lot the same. Everyone kind of thinks I'm 25 right now. I have not aged a ton over the past few years. So anyway, we'll do that. But let's move on now to the Periscope technique. Now, first of all, this is something that I'm sure legal would want me to say for everything, that beyond the fact that all of this is general advice, and of course you want to find whether it applies personally to you, so talk to a clinician before pursuing any course of clinical action, but also Periscope as a trademark. There is a trademark relating to minimally invasive surgical services, which we do. There's a trademark relating to a website that talks about it. And there's also one for instruments that are used for evaluating the gynecologic anatomy. So there are all kinds of things that relate to that. The Periscope technique, as it's alluded to, which we pioneered and is sort of known for us, the technique is known for using air-infused saline hysteroscopy to see if the tubes are open. And I'll explain all that. And then the broader approach is how you combine that with ultrasound to sort of have a broader context for female fertility. And so here's a thing I always emphasize for people. I always say fertility isn't easy, but it's simple. It boils down to four things. A guy has to have sperm, woman has to have eggs. They've got to meet in the tubes and have a place to go in the uterus. It's not that there aren't things that aren't incorporated in that, but I often estimate for about 90-95% of the things that are common and readily detectable, it will fall into one of those four categories. And so if you have a good grasp on those, and I think that still, it's still hard to pick up stage 1 endometriosis, although that's in a category by itself at stage 2. At the same time, if you can understand those well, you can often figure out the essentials for helping people conceive. So we'll talk a lot about that. And so we look at a sort of a systematic approach to fertility testing. Ultrasound, if you are counting the number of eggs that are in the ovary, this is called the antral follicle count. Now the ovary normally looks like a chocolate chip cookie. You'll see the circular structure, a lot of little black spots going all the way around. Looks like a chocolate chip cookie. The more chips, the better the cookie. The more black spots we see, the more eggs you have, the better off you are. So the ultrasound can really give a realistic and reasonable predictor of ovarian reserve. And again, if you use FSH, we often refer to that as a test of the past. So the antral follicle count is very favorable. By the way, I'm going to occasionally send out the love and shouts to all the people who are logging on, saying hi. So I appreciate everyone who tunes in for these videos. And please comment and say anything that you feel relevant and supportive of this community. We want a supportive environment for all the people on their journey. So we figure out where those are, and we can predict whether a person's 30 or whether the ovaries may be 30 but acting like they're 40, or whether they're acting like they're 20, where people have more robust reserve. But if you combine an antral follicle count with a person's age, you can figure out most of what you need for ovarian reserve. Not that there aren't exceptions. Nothing for any test is 100% in the field of fertility or for medicine in general. But for the most part, you can figure out for almost all patients, you'll have a reasonable estimate as long as you can know their age and see their ovaries well with which to get an antral follicle count. And there are some rare exceptions. And the next is also for looking at the uterus. Ultrasound is very good for the outer uterus, but for the inner uterus where pregnancy develops, there are often things that are hard to see with ultrasound. Ultrasound can often be better for fibroids, which take up a lot of space, generate a lot of signal. You can even see for larger polyps that are picked up with ultrasound. But the thing is, if the polyp tends to be in the corner of the uterus where the tubes connect, that's very easy for the ultrasound to miss. You have infections, which is chronic endometritis, and there are changes you can see for the uterus that are often missed with that. And you can also see that there can be scarring. Even Asherman syndrome, you would think you would pick that up, where the top and the bottom of the uterus fuse together. That also can be missed, and hysteroscopy will pick that up. Now for hysteroscopy, everyone reads online about these really large, painful cameras, and they kind of freak out. We use really small cameras. The focus that I use is a 2.8 millimeter flexible hysteroscope. So I always joke, it's small enough to go in the male bladder in the office without anesthesia. If it can go in the guy's anatomy, most women can handle it well. There are some rare cases, or I would say, most women do very well. Most people compare this to a pap smear or less for the degree of discomfort. The core people where you see more discomfort is if they have baseline discomfort, so they have a stage 4 endometriosis where they need pelvic rehabilitation therapy for the pelvis, or they've just, I've had a person recently where she had to go to the ER for every single period that she had, or many of them, or routinely. When people have such extreme issues for the pelvis, most of the things that are done for it can cause a degree of discomfort. And so, there's a lot of that's not specific to just this particular test. The other thing where you watch a little bit more for that may be more specific is two things. If the tubes are closed and the cervix are closed, it makes things more uncomfortable because if you're putting fluid in and it can't get out, these cause a greater degree of discomfort. Think of when so I always say, think of Thanksgiving dinner. If you're normally eating and you're over full, you're uncomfortable. But if you're really, really stuffed, Thanksgiving dinner, it's not over when you're full, it's over when you're ashamed of yourself. If you are having the cervix closed off, so there's a tight seal, so if this is the hysteroscope and it's going around, and it's a very tight seal relative to if it's more open and fluid can come around in this space and get out, that makes things a bit more uncomfortable. So if you have a tight seal, that makes it very hard. And then if the tubes are closed, that's like a balloon where it stretches and things go in and they can't get out. So you usually are watching for that tight seal for people who've had previous chlamydia, or they've had previous freezing of the cervix, or some people just naturally have it. And then people who've had tubal ligation, or they've had, again, pelvic inflammatory disease or extensive endometriosis, which have closed off the tubes. Those are all things that are meaningful risk factors that make it hard for fluid to get where it needs to be. And those can cause discomfort. Most people do reasonably well, and then also there can be cramping again if you have the cervix closed off and you have to open it up. But that's where you're trying to fix it. And most people, again, if you want to be really comfortable for that, you get anesthesia, you're out cold, you're asleep. But most people say, hey, that's $1,000, $2,000 going to the OR or getting anesthesia. If you can have it crampy for 30, 60 seconds with a dilation, save the money for $1,000, $2,000. And most people will do that. But again, I think it's individualized and you have to find your own comfort level. Anyway, once you're in the uterus and you're finding all these things that are sort of, potentially going on, you want to try to fix it and see as much as you can for what things are normal. And then that gives you a really good sense for what you have to do about it. Now let me show what it looks like for the inside of the uterus. I'm going to rotate the camera and I'm going to show a bit more of sort of how it looks to us during hysteroscopy. By the way, the resolution we have in the office is much better. So if you are, I apologize for doing a video recorded, now projected through a live stream. The resolution is going to be less. But hopefully it'll show you what you need to see for things. So let me pull up a video for that. So 1 second. It'll take me a second to get over there. Let's see here. Okay. All right, let's go back just a little bit here. Okay. So now I'm going to rotate this. And by the way, for Facebook, for what they want us to do, they always want to announce if there's a component that's not live. So of course, the fact that I am actually showing you a video that's pre-recorded, and I'll show a few of them but they're pre-recorded even though this is a live stream, just to clarify that. So let me click on this. So this here, I'm going to try to zoom in for the monitor here. So hopefully we've got things there. Let's see here. And so this is, so right in here, this is the cervix. So the gateway from the vagina to the uterus. We're coming along and into the uterine cavity here. And so it's advancing along, and I'm just going along the cervix with this very small camera. And right up in here, as about to get here, it's a little narrow at the inner os to connect to the uterus, but now we're coming into the uterine cavity. So this is where a baby grows in here. And what you'll see is there are these two bumps. There's one right up here, and then there's one right up here. The rest of this uterine cavity, things are very smooth, and I apologize for everything moving around a little bit for it. But you see these bumps here. Those are polyps. Now polyps, if they are in the wrong place, they can actually decrease your fertility. And I'm adjusting the screen here. So you want to actually figure out when you have growths like this for two reasons. One, they can progress and they can become cancer, and which is obviously not anything anyone wants for things. The other reason, beyond the fact that they have a degree of cancer risk, is that people believe that if they bleed, they can irritate the lining, and then that can lead to a less hospitable place for pregnancy. In fact, the one randomized controlled trial called Perez-Medina showed that if you remove polyps, people were about 3 times as fertile in subsequent months. By the way, we're adding air bubbles. You're seeing them zip out each corner. That's where the fallopian tubes were connected, and then we were done there. So, so we were just seeing whether the tubes were open there, on top of the fact that we found something that could potentially result in cancer if ignored, as well as distracting from fertility. So that was a quick approach. We also did that vaginoscopically, so we didn't have we didn't use a speculum for doing that. I didn't point that out, but let me just show you another person. This was a person who had had a miscarriage and had a D&C, and the inside of the uterus was sort of scarred as a result. Now, that normally doesn't happen. Most of the time after a D&C, people are fine, but you see this band that's fused here in the center, where the front and the back of the uterus have fused. That's bad. You don't want that. That's sort of taken away the space, and if an embryo were to implant in this area, it wouldn't be able to attach as well because it doesn't have the normal blood supply. So there's a band that's right here, and I'm seeing the fallopian tube connect in this corner back here on either side as I sort of roll the hysteroscope around that band. It's right up in that corner. I'm just sort of coming back, looking more at the rest of the uterine cavity. Again, there's a band here, there's a band here. I'm actually coming down now to this other side. In a second. Sorry if anyone's motion sick from this. There's a band here, there's a band here. All these bands, more bands than a live concert. It's unfortunate to see these many for things. All of these are sort of detracting from pregnancy and making it hard for this person to conceive. And she'd actually had multiple failed pregnancies previously. And then when we were able to remove things, she did better. So this is really important. This is a person actually for this video where this person had recurrent miscarriages and nobody had picked this up. But you see this growth where there's sort of these fronds and everything in the middle. This is actually retained placenta from a previous pregnancy. And it was inflaming the uterus where it made it very hard for a future pregnancy to develop. There, by the way, there's some small micropolyps there. Let me just go back and show those. Again, sometimes, let's move back. Sometimes these can overlap with a chronic infection. And so they're right here, here, here. That may or may not be the case. She's got so much inflammation going on throughout the uterus, but she absolutely needs this out with which to be able to get pregnant. And then the final video I had for this was just, this was a person, as we talk about things, where she'd had, this is, again, just going into, we were finding the cervix, here we go. Takes a second, I'm just finding the angle. Oh, I'll tell you what, that doesn't really help you. But this is vaginoscopy again, where you don't use a speculum to make things more gentle. And you're coming into the uterine cavity, and you see, excuse me, allergies for things, right up here in the corner, or I'll tell you her background a bit. She'd had previous pre-cancer, it's called endometrial hyperplasia. She'd been given megase for treatment, so to hormonally suppress the potential endometrial cancer. And then they kept giving her hormones and then biopsies and hormones and biopsies, and basically went through several years of this. And finally they said, okay, on the biopsies everything is normal. But they would occasionally find something and then they'd start all over again. Well, if you go with the hysteroscopy, you find that disease right there. There's really sort of all these blood vessels. There's some disease right up in here, everything like that. And what was happening, and this is a polyp that's on the smaller side, but that could also be a problem. For someone with previous pre-cancer, there's some more, again, right there. You don't want to be having, there's some, you don't want to be having these things in the uterus. And so what was happening for her is she would actually get, and there's, again, the disease back there again. This is a person where she would get a blind biopsy, and I'm sorry, the resolution is too low. They'd sample in the middle of the uterus here because they couldn't see, but that's where the catheter went. And then the disease up in this corner and up in this corner would be missed. This person could, fortunately it ended up not being cancer. But this was a woman where had any of this stuff been done and evaluated through hysteroscopy, they would have actually been able to pick it up and treat her years, and she wasn't getting this, wouldn't have gotten all this medication that made her gain weight, and they would have been much more accurate and effective in treating things. So people can have problems within the uterus that are missed with blind biopsy, they're missed with ultrasound, and if you go in, you can see it. And so again, as we get back to sort of some of the reasons why we do things, that we pick things up that others have missed. And if you're saying, okay, again, ultrasound to understand the ovaries, ultrasound with hysteroscopy to understand the uterus, and then the air bubbles to see if the tubes are open. Again, the true gold standard for the tubes is laparoscopy, but a lot of people pay $10,000 for they have a $10,000 surgery, but a $2,000 deductible, incisions, anesthesia, and some time for recovery. A lot of people are saying, hey, if you can figure out most of that with a 15-minute office procedure, that gets a lot of people where they want to be. Moreover, it's sort of gentle, it's accurate, it's fast. Again, for the gentleness, I talked about that where most people say it's a pap smear or less, with rare exception, or not rare, but you would often say about 10%. And usually that's because of the underlying diagnosis where you're either trying to fix something or they have something meaningfully going on already, which is sort of making their experience different from that of the average person. You then also say, okay, it's accurate. Again, we estimate that 98% of the time, that was a study we did, 98% of the time if there was a blockage, we could pick that up. That's very important to be able to say, hey, if my tubes are blocked, I know it. Now, sometimes the tubes will fool you. They'll act closed when they're actually open. And so you can also use a fluid from the ultrasound, and I'll explain that if you're ever undergoing it, for seeing how whether fluid escaped through. And sometimes you have this disconnect where the bubbles didn't get through, but then fluid did. And we'll talk about when people fall in between for what that means for their chances. And particularly if the uterus is backwards tipped, sometimes it's harder to get the bubbles where they need to be. So there are all kinds of things that we can still figure out, even if it is less than perfect conditions for things. And again, the body isn't always easy, but the question isn't whether I think this test is perfect. I think it's really good. I think for what can be done in the office, I prefer this to the alternatives that are out there. But the question is, what's the alternative? And if you're saying you're going to laparoscopy with the costs, the risks, all those other things, that usually should not be a frontline approach. Similarly for HSG, for hysterosalpingogram, not only can that, I think that costs more for many people relative to the value of the information provided. Plus, people don't like X-rays unnecessarily, and they can have allergic reactions to the contrast, and the dye is kind of sticky, and all those types of things. I find this to be a more informative approach than a lot of the alternatives for things, which is why we tend to lean towards it. And then again, for fast, usually, so even though I've shown a few videos which were a minute or two, I often will talk longer. I like to teach and explain things, so I go over everything as we go about it to explain where the body is. And, but as long as people are comfortable, again, you can go longer. If you are uncomfortable, then we could try to go really fast for things. But and then for safety, I see very rare infections. I estimate, again, for a lot of approaches, it's 1-2%. Some even put it at 5-10%, which seems high for me. I tend to see more 1 in 1,000 or so from personal experience, or less. But again, if people have abnormal fever or discharge, they let us know about. We'll get them antibiotics. And so that's how we can see a lot in a short period of time. The challenge is then, what do you do about it? And if you find polyps, you want to remove the polyps. If you find infection, you want to get antibiotics. If you've got scarring of the uterus, you want to clear that away. If you have fusion of those bands, or you have a septum, which is where the uterus didn't develop properly in the as an embryo, we find out ways of sort of cutting that back to make a more unified home for the baby, so to speak. There are all kinds of things that you can do for this. And I think that's the broader challenge for everyone. How do you understand where the body is so that you can fine-tune it and ultimately get people where they need to be? And this is really one of the important concepts. Everyone worries about testing because they're like, oh my gosh, what if they find something? Well, here's the thing. If you've got something going on that's wrong, it's still there whether you've tested or not. The difference is, can you learn and gain control and improve the body? And even if you can't improve the body, at least you know what you're working with so that you can make the right decisions for, hey, for what I'm doing, these are my chances in a month, and this is what I have to do in order to maximize the likelihood I get where I want to be. And so, I generally find for the most part people are pretty happy at the end of this, because if they're normal, they're really happy they're normal, and if they're abnormal, they're like, oh my gosh, this has been going on for years. People have missed it. How can I? What do we have to do to make sure that things are okay and get it back to where it should be? And so, in some ways, either way, it is a win. And so, I think ultimately, so much of fertility, so much of life is how do I regain control over everything? And so we want to empower you to understand your body. We want other people to do the same. And I think you guys tell us what you want to know, what we can explain, what we can do. And it's also, by the way, I would say, this is another thing. A lot of people just talk about their testing as though the fact they had a test. But it's not just whether you had a test. It was how good was the person doing it. Was it a radiology tech who does, 1, 2, 3 a week and doesn't give an interpretation? Or is it a nurse? And there are some very skilled nurses out there for things, but then, or is it someone who's actually, pioneered the technique? I always joke with people, hey, if you were having heart surgery, would you want the person who invented a particular heart procedure to personally do that and has done thousands of them, or would you want it just being a random person? That who you get to do things also matters. Although I do believe in moving beyond titles, and I think there are some people without very formal titles who actually do a phenomenal job, and there's some people with fancy titles who actually don't do that great of a job. And I think the hardest thing is for you, is as a person trying to understand the care you get, is who do you trust and who knows what they're doing. I hope that we can help you understand your fertility, or that others can. Thank you for tuning in. That's everything I think I was going to do today. If you have questions, send them in to us. If you have want us to do another topic, let us know. I'm up for anything you guys can do for us to add on for information for these things. Thank you for also for those of you supporting ASRM and reproductive research. Also, I think I haven't decided definitively, but I want to talk about cancer and fertility for the next one for the November broadcast. And we have a story from a cancer survivor who's going to be coming up, where we did her egg retrieval Christmas Eve of 2009, and now she has she's again 10 years out from her cancer, 11, and now has a child from everything. And so the wonderful, heartwarming story for someone who's been through these challenges and has made it to the other side. But again, if you have other topics, let us know. And thank you all. Stay safe. Look after yourselves and help others. And thank you again.